So if you guys are ready, I'll go ahead and start by introducing our speakers here today. So first we have Dr. James Ghattas. He was born in Marietta, Georgia, and Dr. Ghattas grew up on a lake surrounded by acres of wood. Families from Alexandria, Egypt, which makes him the first generation American, such as many of his colleagues. James went to high school and swam competitively for U.S. Swimming in Fort Lauderdale, Florida, and began his bachelor's degree in microbiology at the University of Florida in Gainesville. There, he sang and played guitar for several bands, including Red Hot Chili Peppers, Cover Band. He spent years researching botulinum toxin for the treatment of post-stroke capacity before getting his medical degree at Lake Erie College as osteopathic medicine, if I'm pronouncing that correctly.
That's correct.
Joined the University of South Florida. He then joined the University of South Florida, where he completed his residency and board certification in adult neurology. He's currently pursuing his subspecialty training in interventional pain management with emphasis on regenerative
orthobiologics.
Orthobiologics, there we go. And then we also have Dr. Omar, and he was born to immigrant parents from Cairo, Egypt, only weeks after arriving to New Jersey. He was raised in one of the most diverse pockets of the United States. Dr. Omar became keen to the flourishing nature of human perspective. After obtaining his bachelor's degree in economics at Rutgers University, he embarked his journey in medicine starting on the beautiful island of Grenada and culminating in Brooklyn, New York. When he obtained his degree in medicine, ultimately he went to Boston University, where he completed his residency training in anesthesiology. Currently, he's settled in Tampa, Florida, where he's pursuing anesthesiology. There we go. He's currently settled in Tampa, Florida, where he's pursuing his advanced subspecialty in training in interventional pain medicine. And Dr. Omar strongly believes in lifelong learning and endeavors to integrate his training in advancing medical education, patient education, and patient experience. So welcome, doctors, to the stage. It's a pleasure having you guys here. Super excited for you guys are going to share with us today. And the stage is yours.
Thank you, Mateus. That was a tremendous,
thanks for the lovely introduction, Mateus.
So I'm Dr. Ghattas. You can call me James. This is my colleague, Dr. Omar. And first of all, we just want to give a big thank you to Sunken Blimp and the design team, Mateus, Abril, everybody. You guys are true professionals. Putting this together for us is incredible. So thank you again. So basically what we want to talk about today is a number of different things. And we want to start kind of broadly to help you guys understand the concept or how we came around this concept. We're going to dive in a little bit deep, pun intended. We're going to dive deep into Mo and my specialty, interventional pain management, to give very specific examples. And then once we kind of talk about the nitty gritty, then we'll zoom back out and see how we can apply this to, medicine in general and really any STEM field. And that really is, how do we incorporate, the new technologies that we all have access to into medical education and training? How do we supplement it, essentially?
Right. So we really just want to establish the framework for what exists now in the current medical education system, and then explore how we can change the way we think about medical education, surgical training, medical training, using emerging technologies like AR and VR to sort of meet the demands of this evolving world. And then having established that, like James said, we'll sort of explore our longer term goals. We'd love to hear the perspectives of the audience. I know there's probably a lot of backgrounds from a lot of disciplines here, so we would definitely appreciate your perspectives as well. Anyone here in medicine? Maybe a clap if you are. Okay, good. So most people aren't. So I'll sort of establish how it goes when you decide you want to be a physician. So first, there's the first 4 years of university. That's an undergraduate degree that many people get. And then from there, you apply to medical school, and then you start medical school, and that's 4 years. And that's basically split into two halves, right? So the first two halves, we can go over. The first two halves.
Yeah, if you guys want to follow us up to the top of the stage here. We're gonna basically walk around the stage while we talk, if that's fine with you guys.
Right. So the first 2 years of the 4 years is essentially just book studying. It's the basic sciences, anatomy, physiology, pathology, biochemistry, things like that. So and again, this is the biological science, so it's not necessarily abstract or too difficult to comprehend, but it does involve a lot of sort of rote memorization, just repetition, studying over and over, reading over and over, taking notes, things like that. One interesting component that's existed probably for the last 50 plus years in medical education is an anatomy lab, which essentially is a cadaver lab where you can go in and you'll see donated cadavers and sort of study anatomy that way by seeing it live. Over the years, that's become a lot more difficult, right, in terms of regulation, cost of cadavers, sort of the number of students and how many can utilize a cadaver. And so in the last year or two, especially with COVID, I mean, when I was in medical school, I was able to access that lab probably once a week. And even then, it was only about an hour of formal learning on the cadavers. That in my same medical school last year, they had no access to the cadavers, and I think a lot of schools are doing away with them, mostly because of cost. Anyway, from there, you'll the second half of medical school, you'll hop into your clinical rotations, which is when you hop into the hospital for the first time. So now you're really getting thrown in to sort of apply the basic sciences applying it to actually treating patients. And so you're learning hands-on, you're learning on the go. And then, once you complete, you'll rotate through different specialties. You sort of see what it is you want to do when you grow up in terms of the type of medicine. And then you graduate with a degree in either osteopathic medicine or just a degree in medicine, right? So from when James and I both started university, that's 8 years. That would be 8 years just to get to that point. And at that point, we both have the same formal education, right? Regardless of how creative your medical school tries to be, there's sort of standardized exams and a very standardized way to get through the system. So that's medical school, right? So we got college, university, medical school, and then you hop into your residency. And this is sort of your specialty training. So this is where people really start to branch out into different specialties. You can do primary care, surgery, general surgery, neurosurgery, anesthesiology, neurology. This is really where your learning branches out from your peers in medical school. There, you're directly involved with patient care, patient decision making. You always have a cushion in terms of a superior who can sort of correct you if you're wrong. And when you complete your residency, you're expected at that point to be able to practice independently.
Mo, if I could interject.
Go ahead.
So they call it residency because the main way that you learn is just sheer repetition. They call it residency because you are literally a resident of the hospital. You're spending hours upon hours upon hours overnight, 36 to 48 hours at a time taking calls. So essentially you can do these kinds of things in your sleep. By the end of your training, depending on what specialty you're in, you could be, your thought process and your thought patterns and the way you practice in your discipline could be vastly different from your colleagues who you were just studying with for 4 years in medical school. I mean, one of the biggest dichotomies is surgical versus non-surgical medicine. I mean, as a neurologist, my training my practice is primary clinical. We focus on a good history, focus on a good exam, we make a diagnosis, and we come up with a treatment. And I'm not necessarily operating on anyone, as opposed to, a surgeon who they have to learn not only the clinical aspect, but the surgical and procedural aspect. So it's just your practices are vastly different from one another. Back to you, Mo.
And that's right. And that's important, because if you think about it, medicine is a very broadly, it's very collaborative, right? So it's one human being with multiple organ systems, multiple different issues, with experts in different specialties trying to collaborate to ultimately, provide the best care for a patient. You'll see, as James mentioned, I mean, specialties are vastly different in terms of how you train and what you train in. And so we really do see that closing that sort of gap between specialists and helping them understand each other's specialty with the ultimate goal of treating the patient is super key. So, when you complete your residency, you can go on and practice in your specialty, or you can do something called a fellowship. And that's actually where James and I are in our current state. We're doing a fellowship in interventional pain medicine. So you can do a fellowship in interventional pain medicine from certain specialties. So one of them being anesthesiology, like myself, neurology, like James. You can come from physiatry as well, and a couple of other specialties like psychiatry and emergency medicine. The goal of an interventional pain specialist is to treat what we call chronic pain. And so chronic pain, by definition exists for 3 months or more. Many of our patients have had chronic pain for, 20, 30 plus years. And so our goals are really to identify the issue, understand the disease process, but ultimately in terms of treatment, we try to approach it from a multimodal approach, right? So it includes medications, physical therapy, but the main thing that we offer and the specialty is trending towards is interventional procedures to sort of block patients' pain.
Yeah. So traditionally, up until maybe in the last 20 or 30 years, the way, well, first of all, pain was neglected as a syndrome. People would come in for sickness and things like that, and you try and treat this disease or illness from a very pragmatic point, and oftentimes overlooking what brought the patient in the first place, which is, "Ow, doctor, it hurts. What do I do about it?" And we're discovering now that pain being left untreated has tremendous physiologic impacts, psychological impacts. I mean, it's one of the leading causes of disability in America as well as around the world. Like back pain and migraines are one of the most common diagnoses on the planet, and it costs, it costs the workforce quite a tremendous amount of money. People going on disability, they can't work, they're not a productive member. Anyways, so traditionally, pain management has been, if not neglected, has just kind of been a band-aid. Take this medication, it's going to make the pain go away, but it never really addressed the issue. So what interventional pain management is, how do we, number one, identify what is causing this person's pain? Number two, where exactly is it coming from? And is it something that we can target with a needle? We can target physically. And once we can identify this pain generator, whether it be from some of the joints in the back, whether it be from irritated nerves, whether it be something just inflammatory, if we can target it, can we intervene on it and knock out that, source of pain without the burden of medication and side effects and psychological side effects and things like that. So if you look up here, these are just kind of some brief illustrations of what we do. You have a gentleman who looks like he's staring at some Xrays and he's holding, a needle. I think in this case is like a marker. So he's getting ready to inject. But basically, once you have a patient, you identify what's hurting and what we can intervene on. Then we try and intervene on it or identify it through an X-ray, and then either inject some sort of anti-inflammatory medication or an anesthetic agent. And in even some more advanced cases, we can actually use what's called a nerve stimulator or a spinal cord stimulator to implant it along the spinal cord and modulate the way your body processes and perceives pain. But we can dive into the nitty-gritty a little bit again later. I just wanted to expand on what Mo was talking about. You go through this essentially 12-year sequence of education, college or high school, college, med school, residency, and then fellowship, whether or not you decide to do it. And you can imagine that that's a lot of information that you accumulated. And it's not just, volume-wise a lot of information, but it's also a lot of different kinds of information. And you have to draw upon them in many different ways on any given moment throughout your practice. Typically when we approach some sort of disease, let's say chronic low back pain, that's something that him and I see constantly. Well, first of all, you got to know the anatomy. And to understand the anatomy, you have to remember all those illustrations you saw in your textbook. You have to remember that cadaver that, you may or may not have had access to. You have to know, what are the implications of all these, components of the anatomy. Then on top of that, you have to understand the pathology. What can go wrong with this anatomy? If I can grab a model, I might be able to bring one over and just kind of demonstrate. There you go. So let me just shrink this down a little bit. Okay, so here we just have 3 vertebral segments, and this is kind of a rough illustration of it, but we have 3 vertebral segments here from the lumbar spine, so in your lower back, right? And what you have is, if you want to approach this from kind of two ways, you have this front part here. Let me just walk up to it. So this kind of front part right here, which is the vertebral body, this is the bone of the vertebrae, and then you have these little discs in the middle. This is like the weight-bearing portion of your spine. So every time you stand up or sit up or you're carrying anything, this kind of front portion of your spine is what's carrying the load. And then in the back, you have, let me just blow this up a little bit more. In the back, you kind of have this posterior section here. And you'll notice that there's little bones sticking out and there's little knobs here and whatnot. It's a little bit more complex. Well, this is what we call the articular part of your spine. And this is what enables us to do all the fun movements we like to do, like yoga, a lot of side bending, flexing, extending, twisting. So you can imagine there's a lot of kind of delicate mechanics here. Something that commonly happens is that, as we get older, the discs in this front part of the weight-bearing part of the spine here, they start to kind of dehydrate and they lose they're not as robust as they were when we were younger. And so they kind of lose their height. And when this disc loses its height, this 2 vertebrae, they get closer to each other. And some of the weight that was otherwise supposed to be dealt with here gets transmitted to these delicate structures in the back. And these little delicate structures, like this one I'm touching here, called the facet joint, these little delicate structures, they get overworked. They don't like to get overworked. And when they're overworked, they get inflamed. And when they get inflamed, you get arthritis. And everybody here kind of briefly understands what arthritis is. It's like that wear and tear, painful wear and tear of the joints. That is probably one of the most common causes of back pain around the world. And it's that aching back pain that you just feel right at the top of your buttock, just right in the low back. It's nagging always there. And so traditionally, you would give medication and anti-inflammatories that have all kinds of side effects, and they wear down your kidneys and they wear down your stomach. Or what if we can target the source of the pain? What if I can find the nerve, so this kind of black nerve here, if I can find the nerve that provides sensory information from this joint and block it with an anesthetic medication, and blocking the transmission of pain to the brain. So that's just an example of something that we do on a daily basis. So in order to get to that level, you have to understand the anatomy. You have to understand what goes wrong with the anatomy in order to cause some sort of pain syndrome. And from there, you have to understand what are your treatment options. like, medication, all the side effects that go with medication. How is it metabolized? How does it interact with other medications that the patient might be on? Oh, excuse me. And then other treatment options like intervention, injections. In order to do injections, you have to be able to call upon all the diagnostic modalities that you may have learned, MRIs, Xrays, blood work, things like that. And then you got to learn how to interpret those. And then once you interpret or figure out how to interpret those, you got to know how to apply them clinically and, understand the little nuances and differences from patient to patient, understand that not every patient really follows the exact textbook model, kind of build that imagery in your head, and then, conduct your treatment. And then once you're done conducting your treatment, you have to understand, okay, what's the long-term plan now? How do we manage this person going forward? How do we navigate potential side effects or complications like infection, bleeding, things like that? How long do I want to follow this person up for? Traditionally, is this treatment going to be effective for a week, 6 months? Is it the only treatment that the person needs? So I guess the point I'm trying to make is you have to build many layers of knowledge, and every layer of knowledge that you obtain through medical school and residency has its own intangible obstacles and its own difficulties. And some people learn faster than others. Some people learn better with visuospatial things. Some people learn better with reading. Some people just go to lecture once and they barely pay attention and they just remember it forever. So those people are fortunate, but not everyone's like that. So yeah, you just have to build upon several layers. Go ahead.
An important thing James, mentioned. He gave an excellent run through as to how he sort of understands the disease process itself as it's happening in the spine, right? And so, as years have progressed, if you rewind 50 plus years ago, it's the same spine, and our understanding of it is pretty much it is very similar. We've added many layers to our understanding. But James did touch up on some really important elements, right? In terms of diagnostics, in terms of what procedures can be done. These are all advancements in medicine that are happening alongside you, regardless of whether you're keeping up or not, right? And so the way that this information is delivered to you at one point, if you were doing a fellowship 50 years ago, it was probably most important for you to understand the disease process and understand the medications. If you did not find a way to progress your knowledge alongside the advancements that are happening in medicine, for example, not just doing a physical exam, but doing an X-ray and an MRI to really get a visual image of what's happening and how to interpret it, you're going to ultimately become deficient in how you can help your patient. The same applies for the therapies. So again, a long time ago, it was just medications. I'm sure many people here have heard of the opioid crisis, and that's not really a long time ago. That's happening now. So if you at one point were only treating your patients with medications, you eventually you're going to enter a space where you're not doing the best thing for your patient, because there have been advancements in therapies to better assist your patients. The issue becomes if medical education does not keep up with these advancements, and that's an important sideline for this talk today too. You want to hop into go
ahead. So that whole spiel I gave just a moment ago about all these different layers, I came up with a nickname for it. I call it the medical Big Mac, because at the end of however many years, you have this delicious sandwich of medical information that you can take out in the world and help people. I'm trademarking that, by the way.
Yeah, you heard it here first.
All right, if you guys want, we can kind of move down just a little bit. I want to talk about really we kind of touched on it already, but really the layout of how we learn different things, kind of our current learning format, and how knowledge is, delivered to us, and what kind of obstacles that presents to, to students and residents and physicians. So what I brought up here, this is a screenshot or a series of screenshots let me get a little bit closer here. So this is a series of screenshots from one of my professor's lecture. And I chose this lecture in particular because that professor, Dr. Myers, he's the, chief of academics at my neurology program. And he's one of the most brilliant neurologists I've ever met. He's also a jiu-jitsu fighter, which is pretty neat. But basically he put together this lecture for us that, he gives year after year. And it's honestly, it's a great lecture, right? And what he's doing is he's just explaining, chronic low back pain as a general concept. And then he dives into what are some targeted treatments, what are, how do you lay out the anatomy, behind all these different diseases that we see. And what I really want to highlight is the format, especially nowadays. So traditionally, we would get together on a Thursday afternoon after eating a very carb-rich lunch and everybody's kind of sleepy, and would be sitting here staring at a PowerPoint presentation. And the first obstacle is don't fall asleep from the lunch you just had. The second obstacle is while the professor is talking, you're trying to read detailed information about, mechanisms of action of certain medication. You're reading the outcomes of some PhD's research that he did for 30 years, and it kind of, highlights one facet of this slide that we're talking about. And then, you can see here that he gives a picture of an X-ray, and you're supposed to, from this tiny little picture, interpret that, oh, this is a hip, this is the patient's right hip, this is the hip socket. What is that little black streak there? I've never seen that black streak before. Well, now you got to understand that black streak means that someone, a physician, injected a type of medication that shows up black on an X-ray. And you got to understand that kind of where it is, it's most likely sitting in a muscle called the piriformis muscle. That's a lot to kind of interpret from this one static little image. And then
just imagine James and I on our first, in our first week of this fellowship, where we're going in now and we're presented this, and we just see these images, and there's really not much context other than, this JPEG.
Oh, and then at the end of that lecture, and later in the afternoon, you're expected to go down to the procedure suite and do this procedure on a live person. So you can imagine that there is a large knowledge gap between what's delivered to us and then what your brain processes and what your brain decides to do with it and how to, conduct it safely on somebody. This is kind of a similar illustration. Actually, what I was talking about a moment ago on that spine model with those little facet joints that get worn and torn, this is the picture that we get rather than, getting this, spine model over here. You're supposed to kind of decipher all that from this black and white illustration with some yellow nerves, which I've seen a lot of nerves. Nerves are not yellow, but traditionally they are. So you just have to understand that, Let's see here. Mo, you want to add anything to that?
No, I just, again, just to emphasize the gap from just looking at this JPEG to ultimately say, you're going to have a patient on the table, on the patient table. You're going to perform a procedure. They're going to be face down, so it's going to look like this. Wait 1 second. There you go. So their spine is going to be facing up, and you're supposed to interpret that from just this picture to later that day, that there are going to be nerves that run down this area right here, and that somehow you're going to manipulate your needle using X-ray imaging to get there. So again, just to emphasize the point that there is a huge gap from a visual spatial perspective of interpreting the anatomy from a 2D PowerPoint to actually performing the procedure. Just want to emphasize that point.
Mo, I brought your needle here to kind of demonstrate.
Oh, thanks. Love this thing. So if you, James, could you point at the medial branches there?
Yeah, let me just get a little closer here. Okay, so on this little illustration, you have 2 vertebrae. Here's your L3, your 3rd lumbar vertebrae. Here's your 4th lumbar vertebrae. There's a little joint right here called the facet joint. And then this yellow line is a tiny little nerve called the median branch nerve that comes out from one of the spinal nerve roots, wraps around this joint, and provides sensory information for that joint. Things like pain, namely. Other information like, where is that joint in three-dimensional space? How fast is it moving? How much weight is sitting on that joint? And as I imagine that you guys sitting in front of me right now might have some difficulty seeing exactly what I'm pointing at. Well, you can imagine that happens in a lecture hall with a regular PowerPoint presentation.
Yeah, all the time. And so essentially, on this 3D model, again, this picture is just showing sort of just straight yellow lines coming down. In reality, what's happening is that these are multiple branches coming off of, so the black in the middle here is the spinal cord, and then there's the spinal nerves that come out. And these are the facet joints that connect this top level to this bottom level. And these joints have innervation, right? They have nerves that pass signals to the brain when there is pain and other sensations as well, but we're going to focus on pain. And really what's happening, and this is just a quick cheap model that we were able to buy for the purposes of this introductory talk, but really what's happening is that there are branches that come off of this spinal nerve, and they travel alongside these bony landmarks here, ultimately to the joint. So when you're having inflammation in the joint, like James said, there's going to be pain signals that are passed back through these medial branch nerves that are yellow on the screen there, and back into the spinal nerve, ultimately to the spinal cord and to the brain. So it's important to understand how they actually are laid out in your spine, and it's important for us to know sort of where along the spine they run and how to get a needle there, right? That's also an extremely key component to what we do. Again, that gap is really just not illustrated well enough, in our humble opinion, on this PowerPoint slide.
And this is no slander to our program. Actually, the program that we're in is, not to pat myself on the back, is a pretty good program, but the obstacles that we're kind of addressing here are ubiquitous. I mean, you go from learning something or seeing something that's flat, static, two-dimensional, you maybe get to look at it for 30 minutes or so, and then you find yourself in front of a patient. And now you gotta, while you're walking this patient through the fact that we're gonna put a needle in their back, you have to do it in a manner that is not gonna hurt them. You have to do it in a manner that is going to be safe. You don't want this needle to touch things that shouldn't be touched by a needle. And so we want to illustrate how can we build upon this using the technology that's available today that either wasn't available before or just wasn't practical before.
Right. There's an accepted learning curve, which in any discipline there's a learning curve. It seems to us that this learning curve continues to steepen exponentially. And at some point, sort of touched on in our intro, flattening that learning curve is important, because medical education will have to sort of keep up with the advancements in therapeutics, in diagnostics, in order for us to deliver care in the safest and most effective manner.
Actually, there's a pretty clearly demonstrable symptom of this steepening learning curve that we're talking about. I mean, 50 years ago, your primary care physician was the guy that was managing your blood pressure. He was managing your diabetes. He was also managing, let's say you fell and broke your arm, he could reset that for you. Let's say your wife is pregnant and he's the one who's also delivering the baby. So I just clapped. The learning curve was rather broad and not as deep then, but now it's gotten to the point where each subspecialty, there's so much knowledge to understand for each subspecialty that it's quite unrealistic to have one physician who's going to be able to be entirely knowledgeable on all these things. And as a result, you have, a primary care physician who essentially is like a relay hub for all his patients' different specialty care physicians. For example, patients don't come to me, just from a direct referral for chronic pain. By the time they see me, they've seen their primary care a number of times. They've gotten pretty extensive workup. They may have already tried some treatments like anti-inflammatories and things like that. By the time they make it to me, it's like, okay, this problem is more complex than I can handle. We need a specialist. So when that patient comes to me, I'm kind of expected to deal only with that problem. And, dealing with problems outside of that realm is not really practical for the patient, because I may give them, information that's not up to date, and it's not practical for me because, we have a lot to talk about within the realm or scope of the specific question that he has. So it would be nice to get back to a place where, physicians can learn a very broad and deep scope of knowledge without having to, spend countless hours trying to interpret or trying to learn in a very old traditional fashion.
James and Mohammed?
Yeah.
Just wanted to point out that we are almost out of time, and that we're going to have a Q&A shortly. So if you guys want to wrap up in a bit, that'll be great.
All right, cool. We'll move along.
Sure.
All right. If you guys want to follow us over to this kind of next section here. So what we have laid out here are a number of different X-ray images. And this beautiful video is actually a video of Dr. Omar's spine. And what we're doing, he sacrificed his back for us. He got irradiated for the sake of education, which is great. I admire that. But what you're seeing here is like a live video of an X-ray while you're taking the X-ray and you're turning it around, and it kind of illustrates the anatomy that we've been looking at pretty well. The thing is that's not safe. Like I said, he's getting X-ray radiation into his body every second that this thing is taking a picture of him. So what we end up doing as a result, and a safer option, is we take still frames, and those still frames give you like a tiny little snapshot of what's going on in time, and you have to be able to interpret what this means. I can tell that when I look at this, that this is a patient that's laying on his stomach. I'm looking at his pelvis. The X-ray is rotated about 20 degrees to the left, and my needles are actually going in perpendicular to the back, but they appear like they're going to the left because we're looking at this from an angle. It took me a year to be able to interpret that as quick as we have.
Right, and if you look over there to the right, it's the same image there, and we tried to demonstrate it with a model right below, right? So that's the same image up top, and we set up the actual model here to illustrate what's actually on the screen. And again, keep in mind that the patient will be lying down, right over there where Dr. Ghattas is.
Yeah. So what you're seeing is basically we took this virtual model here and arrange it in a way that is duplicating what we're seeing on the X-ray. For the sake of time, everything that we're trying to illustrate here is the fact that we're coming into a time where it is increasingly easier for us to use three-dimensional virtual reality technology for a number of reasons. To one, illustrate these kinds of things better, to not only training physicians and students, but also to patients. I mean, this talk that I'm having with you guys, I have this conversation frequently with patients trying to explain what's going on. If I could explain things to patients and medical students and residents the way that we're talking about it here, I think the learning curve would be a lot shorter. Let's see. If you guys want to follow me over to the other side of the stage, we'll kind of touch on some broader concepts, like how can we apply this in pain management, neurology, anesthesiology, really any medical field for that matter. This is not supposed to be a replacement to traditional medical education. Traditional medical education is tried and true. It's stood the test of time. Obviously it works, but we would be remiss not to use the technology that we have available now. And so basically it's a supplement. We want to embrace the technological changes, not replace what's already there. Let's see.
Right.
Mo,
So
do you have
you
anything to add
you
to
can
that?
imagine, yeah. So you can imagine I mean, this is just a very introductory talk, but you can imagine, another setup here at Sunken Blimp where we're actually really diving deep with fellows like James and I, with our co-fellows, and really diving deep into the science and into what the procedure entails, and helping them visualize. At the same time, James mentioned primary care doctors. Primary care doctors are where the average person is establishing their care. And so if the primary care doctor doesn't know that these options exist for his patients, he may never refer to his patient to an interventional pain specialist, right? So this could be a forum as well to sort of educate physicians in other specialties as to what exists in one specialty, right? And then the last point is, patient education and patient autonomy. As James mentioned, we try to verbally explain to a patient. Sometimes we just give them a brochure as to what the procedure is. So that's one component, is just the patient understanding what's happening. But I can tell you, 99% of the time, right before we go into the procedure suite with the patient, you can visibly see the patient's anxiety, right? And I try to, and I know James does as well, he's very good with his patients. I try to, verbally paint a picture of exactly what to expect. Look, we're going to walk into the room, you're going to lie flat on your belly. From there, I'm going to clean off your back with a sterile solution. Then I'm going to do numbing medication, et cetera, et cetera. This could potentially be a forum for patients to see from the patient perspective what to expect, and sort of come in with confidence and full autonomy, knowing what they're getting themselves into, to ultimately help themselves and increase patient compliance. Yeah.
I totally agree. And I see that Dr. Steinmetz, she's a PhD in Colorado who works on orthobiologics and regenerative medicine. She's here. So thank you for being here. You actually reminded me that another really interesting application of all this is remote physician training. Let's say, you are some sort of corporation or an academic institution, you come up with some sort of new treatment or a new procedure, and you want to train a whole host of physicians very quickly, and you can't necessarily get them to come out to you. Well, if there's a way that they can plug into whatever, virtual space like this, and you can walk them through a procedure, that would expedite, the learning, and it would make otherwise valuable treatments available to patients very quickly. I know I just kind of zoomed over to the far end here, but this concept is kind of already happening, and I wanted to illustrate this video here. This is exactly what we're talking about. Let's see if it'll play here. Nope. These people are learning how to do essentially orthopedic surgery using VR goggles, just like the Oculus. And if a resident surgeon or a training physician can spend hours wherever he is at his own pace, practicing this and getting the psychomotor skills down and getting the sequence down and just getting comfortable in that space, by the time he's in an actual OR in front of a patient, he'll be a lot more comfortable, and he can focus on what's important, like the nuances of the tissue, the subtle differences from patient to patient, how to avoid complications, things like that.
Even simple things like becoming familiar with the tools that are used, right? Having looked at the tools, looked at, how they're laid out, what steps to take with each tool, and sort of breaking that barrier before you enter the operating room allows you to really focus on what's important when you're in the OR.
And so, we've gone pretty extensively on, using this in interventional pain management, but this can be applied pretty much everywhere in medicine, not just procedures, but, what about the patient encounter? I mean, you could be super book smart as a doctor, but if you find yourself sitting in front of an anxious patient and you yourself are anxious and don't know how to command a conversation, that encounter might be a flop, and then that affects, the trust, that kind of trust you have between the physician and the patient. So if you could use immersive training like this to acclimate yourself to that environment, acclimate yourself to talking to patients and dealing with difficult conversations, end of life conversations, you'll find that your life will be a lot easier for yourself and for your patients, having been a lot more comfortable with it. I mean, the military frequently uses, complex flight simulators so that they don't crash these multi-billion-dollar planes.
That's right. And I know we're running short on time, so we'd love, just take a couple of minutes to hear some of your perspectives. Thanks, guys.
Thank you.
Amazing. Thank you so much, you both, for the presentation. This was so insightful, especially regarding, you clearly painted the picture of this gap between how we're showcasing these things today and how much this technology could help. And I think this presentation on its own opens so many other potential conversations, from focusing on what you were explaining, that some patients, they have some level of anxiety going into a procedure like that because, in the end, we fear what we don't know. So if you don't know what's going to happen in that table, then you're afraid of what could happen, what is the procedure. And as you can, explain it with details and words and all, but, it's a different thing when you're showcasing, like, this is you, this is what's going to happen. And I think this level of awareness can definitely, help so many people. And then it opens also the other side, right? How to approach an educational system like that. Most of the times, it's a top-down type of curriculum that, a lot of people would not understand from the medical schools. I'm speaking, from what I know about even architecture school, right, which is in a way already more prone to accept 3D models, etc. Still, education is a top-down thing run by people that sometimes don't understand. So how to implement something like this in the educational side is, there are so many different branches to what this conversation could lead to. And it's very inspiring to see you guys present this from a medical perspective. Thank you so much.
Thanks, Matthias.
Thank you, Matthias.
Does anybody have any other questions?
Hi. Can you hear me?
Yes.
Yeah.
Yeah. So I really appreciated the initiative to add technology, and it does make learning really easier. And by the way, I'm a 6th-year medical student in Morocco.
Oh, congrats.
And I would really like to implement this idea in our country.
Mm-hmm.
Yeah.
So you bring up a very common concern, and that is, this whole hour we've spent talking about eliminating, barriers to learning and all these things, but
Exactly.
at the same time, getting an Oculus and getting internet and all these things is a barrier in and its own. I think, and not to sound passive, but I do think that the solution to that with time will begin to kind of resolve itself. There's this kind of phenomenon that occurs with developing countries called sublimation, where, as technology progresses step by step, slowly in developed countries, underdeveloped countries, they may skip an entire step of technology. I'm not sure which country, but there is an example of a sub-Saharan country that they pretty much skipped telephone lines. They went from, not really having much in the way of, like a robust telephone communication system to just cell service with internet. So they skipped an entire generation of technology. I think we might experience something similar to that as time goes on. The interface will be maybe a lot easier as the technology becomes more available and more compact and cheaper. So, you getting a device to wear on your face to enter the metaverse is going to be a little bit easier. Internet access will likely be, Starlink, for example, is going to broadcast internet from space so that you don't have to worry about getting, direct modems and lines and whatnot to, very remote places.
But the beautiful thing, even just this forum today, this is Nasser just mentioned he's from Morocco. I'm sitting in Tampa, Florida. James is actually in the Bahamas right now. I'm sure many of you are in very, very different places. So this is, one of the most diverse sort of get-togethers I've ever been a part of. And so that barrier, which was, it's a really good point because, typically there's this intangible barrier of resources, access to resources. A lot of times that has to do with money, mostly has to do with money. And, it seems like a good proportion of that barrier is already broken with this technology, just by, case in point, us all being together in this forum.
I agree. And then to expand on what Mo said, and Matthias, feel free to cut me off anytime, but there are a lot of intangible barriers. You could be in the hot seat of medical education. You could find yourself in a live training seminar hosted by, one of the most prominent medical device companies like Stryker or Medtronic, and they've gone out of their way to fly physicians there, fly, instructors there. Then they pay thousands and thousands of dollars to get cadavers and things like that. And there's still, you might not come out of that feeling 100% comfortable, because you have to share this cadaver with 10, 20 other physicians. It's kind of crowded. You might not be able to see the X-ray machine the way you want to. By the time you get your hands on the cadaver, the procedure has been practiced on that tissue so much that it's not really the same, or you're worried about, you're still trying to learn the devices, the sequence of events, or like the sequence of the procedure. So with being able to implement virtual training, I feel like you can eliminate a lot of those intangible barriers. By the time you get to the real training, you'll get a lot more out of that training. It'll be a supplement, essentially.
Awesome. Thank you so much, both. And if anyone has any more questions, feel free to ask. But I would just go ahead and say that this is extremely insightful, super exciting, especially like hearing from people that are, in the field, giving their perspective on the potential of this, This is honestly a treat. I hope everyone got something from this. I know that personally I did. So yes, thank you all so much.
Thank you guys all for being here. Matthias, thank you so much for all your hard work, man, and thanks to Sunken Blimp as a whole. This is such an amazing setting to be a part of.
Yes, thank you.
Awesome.
I echo that. And if you guys have more questions, message us on the Discord app. There's a neuroscience section there. Feel free to just ask any questions that you have there. We'll try and get back to you as soon as we can.
Yeah, we'd love to be in touch.
Great. And also something that I mentioned in the beginning, for those that weren't here yet, these dive lives we're having every week, that we bring a speaker to talk about what they're doing, a project, an idea, or anything at all in the Sunken Blimp Stage. And we have a couple of very interesting ones lined up next. And next week we're going to have Professor Neurologist talking about artificial intelligence, the good and the dark side of artificial intelligence. He's a lecturer, wrote a bunch of books already on the subject, so super interesting if you guys are interested. And then also, if you know someone that you like to see presenting on the stage, or any type of specific content that you'd like to see, let us know. Send it in the Discord, message on Discord. If you would like to present a project, you can apply to present on the Sunken Blimp Stage. And this is, a space designed for the community, sharing to the community. So if you have anything to enlighten us with, make sure that you let us know.
Thank you, everyone. Take care. Talk to you soon.